the treatment. So a complaint have been raised to the ministry, and they found that other institutions complained from the same problem, and the company have been changed. Another quality report, which changed the practice in the Gulf countries, not only in Oman. Our report have been sent to the ministry when phenobarbital injection contains benzyl alcohol as a preservative. And this type of material can't be used in a group of neonates and young children. So a report came from the ministry saying that it will be changed to the benzyl alcohol-free phenobarbital one. And of course, we are looking for best practice in the pharmacy to improve the medication safety. So we are looking to safer system to assist reducing the number of the events, the severity of the events, and trying to utilize the information from the reporting the errors to reduce the future one. So we found that the main problem or the errors occurs mostly in the storage area, especially in the wards, where the medications are kept in the fridges or medication trolleys or control cupboards. So we think about a prescription-wise system, which depends on individual patient medication supply, where the medication supplied to the individual patients as per prescription, not more than 7 days, and to store it in the patient care area, and this minimizes the number of drugs issued to the ward. So it looks more tidy and it reduces a lot and helps a lot in reducing the medication errors, because the staff who are dealing with the medication can pick the right medication when they need it. We also implemented guidelines to help the health professionals to follow the best way of therapy. We implemented 3 guidelines. We also produced a pharmaceutical care plan in neurosurgery, orthopedic surgery, plastic and general surgeries. We also approved 2 protocols to be used in OBS/GYN department. We are looking for better and better. We are looking for trained medication safety officers, and there are now 2 clinical pharmacists under training in our hospital. We started medication information center, but still we are looking for well-established one. We started barcoding for the surgical and lab items. We are looking for medication barcoding system. We are working on some of the guidelines, protocols, and care plan, and we are looking for automation in the pharmacy, inshallah. So is there a role for the pharmacist to play to improve the medication safety? Of course, there is a big role for the pharmacist in improving medication safety. As pharmacist Fakhr spoke about the 5 rights of medication administration, pharmacists should respect these 5 rights, and medication should be given correctly to the right patient, in right dose, through right route, in the right time, and to try to avoid any abbreviation as much as you can. Try to review the cases of multiple medication within the prescription and double check. And when I will say double checking in this presentation, I mean double check while you are receiving or issuing, while you are giving the patient the medication. Make sure that the patient understands what medication he is taking and the way he is taking the medication. And if you want to put extra labels, why not? You can do it. And if you have a high-risk medication, controlled medication, try to check it before giving to the patient or send it to the patient. Make sure that it is administered correctly from the staff, and make sure that the patient or hospitalized patient taking the medication knows about what effect he will get from taking this medication. And make sure you are a part of the team. You should be there once they need you. In conclusion, we need to enhance the medication safety awareness, and knowledge. And of course, we need to establish a non-punitive system, a non-punitive culture of transparency. We need to report and analyze our report, follow up our report, and try to give the feedback for the staff about what we got from the result to reduce the future errors. And I can't, I need to say that it's not a one-person job, it's a teamwork. You cannot reach it if you will work alone. You need to be in a team. Thanks for your good attention, and you are welcome to ask any question during the discussion time.
Okay, we have some time for some questions. There are microphones on the stairway. We have about 10 minutes. Any questions at all for any of the speakers? Ask each other questions. That's right. If we have no questions from you, we're going to ask you questions.
This means that we covered most of the things.
Question down here in the center, a microphone down here. Yes, sir.
Thank you very much. My question, I think, is it will be to Dr. Matthew, and I think the others also they can share their opinions. I just want to ask about the reporting, incidence reporting. Sometimes some incidents will be corrected at the same time. For example, a wrong dose, by contacting the prescriber,
Sure.
it is corrected immediately. In such a case, what are you doing in your system? Are you immediately making incident report in such incidences also?
Is that a question for me or for her?
It's for you, and they can share.
You know, so your question specifically about the prescribing end, about how we're addressing that. You're saying? I just want to confirm your question again.
I'm asking about some prescribing errors which are discovered in the pharmacy and corrected immediately with the prescriber.
Right.
Do we need to make incident reports for such events?
Yeah, well, okay, so the question is, you're making all these phone calls to fix prescribing errors, and you're asking, should we be documenting these in a report? So I'm going to say yes to document them, but not in the medication error report. The reason I'm going to say that is, you saw a piece of paper form, she has an example. Some people do not want to stop to fill out a piece of paper form that's 10 questions long when all I did was correct the dose in an order. So I would say develop a mechanism to document that very easily. So for example, believe it or not, there's actually some forms of automation or programs or software that actually capture this electronically, called pharmacy surveillance programs. But think about, to get the ball rolling, how you can easily document. So what was the type of phone call you made? What was the original order and what was the corrected order? But think ahead 30 days. How many phone calls do you have in 30 days? How can you categorize those phone calls? Maybe it's by the type of drug, aminoglycoside dosing, maybe it's IV to PO conversions. Keep in mind, and there's great examples of the studies up here, documenting those pharmacy phone calls is not just about quantifying some of the prescribing problems. Documenting those phone calls is proving the pharmacist's worth. Sadly, some people may be in a situation of being told, I can't afford another clinical pharmacist. How do you prove to me I need another pharmacist? Start documenting these phone calls. And you start realizing how much money you're saving by doing these phone calls. So I would say definitely document them, but not with a medication error report. It would just take too long to fill out the piece of paper. But think of something simple And maybe I would even suggest, if you're not doing this at all, pick a drug class. Maybe it's anticoagulants, maybe it's antibiotics, and only document those phone calls for a month, see what happens. Go to P&T after a quarter and say, hey, we're documenting our phone calls. We've made 300 phone calls about antibiotics. Here are the most common types of calls we've made. So when you present that number quantitatively, you're not blaming anybody individually, but you're also showing that there's a problem throughout the whole hospital. It's not one doctor's problem, it's not 5 doctors' problems. We have a problem with prescribing anticoagulants. So what can you do? The numbers then help prove that standardized protocols need to be put in place, standardized order forms need to be put in place. So definitely document, but document it easily so that the pharmacists buy into doing it. Any other questions? It's a very good question, by the way. I tell you, a lot of pharmacists get those phone calls. All the pharmacists make phone calls, but are very unwilling at times to step forward and start a process of documenting them. I gave you one example of a number. I was at another 3-hospital system in the U.S. Over a 5-year period, they documented over 100,000 interventions in a homegrown database. That's all it was. 100,000 phone calls in 5 years, everyone. What could you do with that information? So, and I guess the other key thing is to make sure you don't come across punitively, as you just described. It's got to be, we have a problem with these drugs, not she has a problem. Are any of you guys documenting any of your interventions at all?
Yes.
Okay. Are you doing anything with the information?
Usually we are send it to the ministry.
Okay.
And trying to analyze it with the department, which is, I told you that we have the department.
Yeah.
So we are analyzing and trying to doing the root cause analysis for it and these things, yes.
Okay.
And trying to change in the system, as I mentioned in the presentation.
Yeah. And some of these information, especially with computerized prescriber order entry, like you discussed, this could help give you reason to build a harder role in the system for dosing of drugs or suggesting certain drugs by quantifying those phone calls. Any other questions? Yes, sir.
My question is directed to Dr. Fikr. Here we came to know that in Saudi they established the medication safety officer. I wonder whether you are in King Fahd Cardiac Center. Also, you have established, the pharmacists have established a medication safety officer, which is very important in medication traceability or medication safety.
If I just understood your question, you said that if we have a medication safety officer in King Fahd Cardiac Center on the top of the other hospital. I didn't get your question.
In other hospitals in Saudi, like Faisal, we came last year conference. They came here, one of your colleagues, and they informed that they have, I think, Al-Miraki, Mariam Dictora, she was the first medication officer in Saudi. They have established medication officer profession there in Saudi, led by pharmacists. In your hospital, whether you have this or in the future your vision to also...
Of course we have it, and we have our director, Dr. Hisham. He is the chairperson of the medication safety, and we already established actually a whole system there in Saudi Arabia. And I think it's almost like 3 years old, or how many years, Dr. Hisham? But another point I need to emphasize that, again, medication errors, it's there. We're human. We do medication errors. I think the way to tackle the error is the important part, because, as you said, we are lacking of reporting because of this blaming, actually, education that we used to have. It's like you blame somebody and you just punish that person. We don't want this to actually to be in the concept of reporting. And that's why I'm going to talk more in details about it in my workshop tomorrow. It's not like you detecting somebody did a wrong or a mistake. No, you are actually trying to see how many of this type of mistakes happen, so how can you come over it. So that's actually the role of medication safety officers.
Yeah, I will say too, luckily at ISMP we've had a relationship with Saudi Arabia, and we've had 3 fellows come over from Saudi Arabia, 2 from Riyadh, to do a year-long fellowship. So luckily we've had some relationships with Saudi to develop medication safety officer qualified candidates, which has been a great relationship for us. Any more questions? Going once.
I have a question for the audience, if you don't mind. Are you done? No more questions? Can you please raise your hand if you did detect a medication error before in your practice? Oh, okay. So it's very common. That's the point. And as a detector, believe me or not, the perfect one to detect is pharmacists. I'm not saying that because I'm a pharmacist and biased to that. No. It's because sometimes you are able to detect something before it happens, because you have the indicators of knowing what type of errors are there. And believe it or not, when I jump to the team, which is the ICU team that I work with, and telling them, you know what, your patient did not respond because of 1, 2, 3, 4. They just feel so happy, and they like it this way. So you see, we do admit that we have medication errors, and I think we really need to improve that part in our practice. Thank you.
And I will also add to that real quick. I want to add that real quick. It's really important for the pharmacists in the room to understand this. And I guess I can say this because I'm married to a nurse as well at home. But you really have to, if you're going to be involved in medication safety, it's not about pharmacy. And the weakness I see in pharmacists and hospital pharmacists, even in the U.S., is that they have no idea what a nurse does. They're quick to pass judgment in the pharmacy and blame a nurse. They've never actually followed a nurse around to know what their day is like, to understand the processes of programming a pump, getting drugs out of a Pyxis machine, looking for drugs, dealing with phone calls, and also prescribing. Also, go into those areas where you're not comfortable going. Hospital pharmacists tend to not go to procedural areas like radiology, emergency departments, PACU, OR. So med safety is not just pharmacy, it's not just med surg floors, it's everybody, and you have to understand everyone's role in med safety. Any more questions? Oh, we have one more.
Is related to medication safety. We are always supporting reporting errors and enhancing this in the environment of working as a teamwork, and want everyone to report mistakes without being afraid of the punishment. At the same time, you are stressing on the fact that every pharmacist should be logged in using the personal account, which is something common in hospitals. So how to deal with this issue and convincing pharmacists, even if you are logged in with your personal account, this doesn't mean you will be punished if you catched doing a mistake or had an error by mistake or something. Because in the same time, if we use like a reporting system that doesn't show the name of the person, this will skip some mistakes or which we need to follow up and see why they what happened. So how to deal with this situation? Thank you.
Yeah, real quick question. When you say personal account, is that like your human resource file you're talking about?
Mm-hmm.
She meant the ID where you are using the computer.
Oh, okay. Yeah, so I guess the question is about basically the fear of people putting their names on a report
Yes.
at the end of the day. Well, I think you have a bigger problem, and that is the culture hospital. Listen, if anyone in this room is afraid to put their name on a report, you have a problem in your hospital. High up. In my presentation, I had put a link in there from the AHRQ. It was a patient safety culture survey. That survey is great because what you do is you get this questionnaire and you give it out to all your staff. And it's anonymous, but you can gather numbers to quantify how many people feel we have a punitive environment in the hospital as an example. The leaders need to understand that. I'm betting many of your leaders may even think that you are non-punitive when your staff doesn't think so. So you have to change the culture. you're not gonna put, no one's going to put a name on a report until a culture is changed. I don't care what you say. It takes one person to screw that up, meaning one manager to fire someone or call you out or punish you. So that whole, especially with management, the culture has to change.
For example, we have in Hola Hospital, you can report, you can also, don't put your name. We are doing the same thing. To report, we will tell them, report the error without putting your name. We are using electronic system also, where there is no names to be mentioned. So it's not a punitive system. Yes.
In our hospital, we came over this now. We're in the stage of putting your name, but it just appears to the officer. So that, again, you don't blame the person who wrote the report. So it's like it's just shown for the people who are concerned in medication error, which is, again, this is what I'm talking about, the blaming issue, which is, I think it's because we have the culture of blaming each other. The other thing is that we did something like last week to encourage people for reporting, is that we said, okay, the more you report, the more you get off days. So it's improving now. It's a part of improving the reporting itself.
Yeah, that's a very good point about, we know of some hospitals in the U.S. that actually give out rewards for people reporting errors. So, some people have competition with the nursing units. Whoever reported even the most reports got free lunch, got something, got recognized with a pen, something like that as well. So, which works nicely. And I think the other thing too is, if your staff does not get feedback in some way from filling out a report, you can fill out all the reports you want. In 3 months time period, if nothing's changed or they haven't heard anything, you're in that position, you've been asked to report errors, number of reports go up like this, 3 months later it goes like this, because no one gives them feedback. So that's really important. And I guess the thing also putting a name on a report is, if you're gonna find out truly why an error occurred, you have to be able to follow up. If there's no name, who do you ask questions to? Not to blame, but filling out a piece of paper and not being able to follow up does nobody any good at all.
Believe it or not, last week we said that, okay, if we had the good reports from the primary care unit, that we're gonna actually give them a lecture and just like serve them a lunch. We had in 1 week 75 reports, which was amazing. Because it was a 0 report, and then in 1 week we had 75. So it's an encouraging process. I think it will work very smooth.
Yeah, and it's a slow process. It doesn't change overnight. All right, on that note, I think we're done with time, so I want to thank my speakers again, and I thank the audience for being here today. Thank you.
Now we would like to request our organizing committee to come to the stage to award the poster winner. We would like to announce that due to higher standard of poster participants, the Scientific Poster Review Committee has decided to award the first and second winners in each category. First, the professional category. The first professional poster winner is Design and Validation of Medication Assessment Tool to evaluate the quality of medication use in the management of bipolar disorder, authored by Dalal Al-Tawil from Kuwait. Second professional poster winner is Pharmacist-Led Asthma Clinic by Zakia Rashid Ad-Dagheshi from Oman. The second repeated professional The second repeated professional is positive therapeutics outcome after counseling and re-eduction insulin patient, authored by Turkiya Mahmoud Al-Belushi from Oman. First student poster winner is Therapeutics Analysis of Methotrexate Therapeutic Drug Monitoring Data to Optimize Therapy in Cancer Patients, supervised by Kyle John from Qatar. Please, all of the group can come to receive the gift. Second student poster winner is Effectiveness of Research Training Program on Improving Pharmacy Practice Research Capacity of Hospital Pharmacists in Qatar, authored by Haneen Ali Al-Rawashda from Qatar. On behalf of our DG and Directorate, I would like to thank our speakers for their valuable information and participate on being part of our event, and looking forward to see you again next year. Thank you very much.